Hello, I'm Ashira Blazer. I'm a rheumatologist at the Hospital for Special Surgery, here to talk to you today about disparities in receiving healthcare, the role of gender and race. Now, I primarily focus on systemic lupus erythematosus, which is an autoimmune disease that can affect multiple organ systems. Now, the individuals who are most likely to get systemic lupus erythematosus are women, and particularly women of color. The incidence and prevalence of SLE is almost double in all ethnic minorities compared to European American individuals. So we also know that lupus is a disease that can cause significant morbidity and mortality. So not only is the prevalence more likely in these groups, but also morbidity and mortality is much higher, with lupus being in the top 10 causes of death up to the fourth decade of life in African American and Latinx individuals. So we also know that race is a social construct. So that means that all of the factors that affect the ability for women and ethnic minorities to receive care also affect outcomes in lupus. So these are structural factors, including ability to maintain employment at the same rates, ability to be educated about the healthcare system, and even where people live in their neighborhoods and how likely they are to get quality rheumatologic care. There are also interpersonal factors. So we know that rheumatologists and the patient population tend not to be culturally congruent. So that means that this primarily ethnic minority population comes into a healthcare encounter, and they're less likely to be seen by a physician who matches their culture, their perspective, or their language. And then finally, there are social determinants of health, meaning all of those factors outside of healthcare that affect one's ability to live and receive healthcare and to be able to engage with the healthcare system. So these are things, again, like education, access to providers, access to medications, access to insurance, and as well as poverty. Now, let's get into some of the data looking at the consequences of these factors. So it turns out that ethnic minorities are less likely to be diagnosed with lupus and less likely to be referred to a rheumatologist upon diagnosis. Now, when we think about what it takes to diagnose a lupus patient, the first thing that has to happen is a patient has to come to the point of care, present a number of seemingly disjointed symptoms that may sound vague to a provider, and have the provider listen well, put those symptoms together, and make the diagnosis. We also know that lupus patients tend to have varying symptoms. So, no two lupus patients look alike, and so that provider may not be taking the time to understand how these symptoms fit together. Finally, access. So people of ethnic minority origin tend to have less access to providers who can really take the time, either uninsured or underinsured. And so these patients tend to have shorter physician visits, and so less likely to have that ear of an engaged provider. And finally, there's co-presentation. So our autoimmune diseases tend to present together or with other conditions such as fibromyalgia or chronic pain syndromes. And this may complicate the diagnosis, particularly in the case that someone is facing bias and structural factors. Now, what is the consequence of this delayed diagnosis? Well, it turns out that people who have to wait over 6 months to be diagnosed with lupus have more severe features of their lupus, are more likely to have morbidity and mortality, are more likely to present to emergency services for their care, where they are likely to be given higher doses of steroids than would be necessary, and finally are more likely to have comorbidities of lupus, meaning all of those other diseases that can go along with lupus, your heart disease, your hypertension, your diabetes. And this together spells out worsened morbidity and mortality. Now, it turns out that when looking at provider communication, hurried provider communication, meaning not really taking the time to sit down and explain the plan of care and also the disease state, associates with damage in lupus, meaning the accrual of injury to the body due to active lupus and also some of the medications that we use for lupus. This is particularly true for African American patients. As well, we find that there are differences in prescribing. So minority patients, particularly African American patients, in one study were found to be half as likely to ever have heard of biologic therapy compared to other patients. They are also less likely to be prescribed a biologic drug. So all of our patients are not learning about all the possibilities for treating their lupus and tend to rely on either older medications or glucocorticoids and steroids, which can also perpetuate damage. Now that we've discussed this, what are our solutions? So there are several avenues that we can take to help decrease health disparities. And one of them is for us to understand that we all carry biases. So we all carry these implicit biases, which may not be conscious, but affect the way that we interact with people from different backgrounds that are not as familiar to ours. So it's important for physicians to understand this and, where possible, get training to be able to gauge when a decision that's being made is based on the interaction at hand or based on one's own bias. In addition, shared decision-making is an important tool, especially when providers who are not culturally congruent with patients are interacting. So, when patients feel that they're getting empathic care from their provider, they're much more likely to engage a care plan and follow through with the plan at hand. So I always ask my patients to understand a few questions. So, do you feel like you're being listened to in your provider interaction? Do you feel like you understand your health and the plan? Do you feel like you're being validated? Or are you coming in saying, hey, I feel one way, and your provider really isn't going into detail about that symptom? Do you feel respected in the interaction? And do you feel like your provider has empathy for you? So as long as these things are met, we know that patients are much more likely to uptake the care plan, continue with their lupus therapy, and that continued therapy is going to lead to decreased morbidity and mortality in lupus. As well, it's important for us to engage other healthcare providers who can help address some of these social determinants of health for our patient populations. So we know that when patients have access to social work, have access to other programs that are able to identify social determinants of health needs, these needs can largely be addressed and can decrease the burden or strain that a patient feels through the course of their lupus care. So be it inability to afford medications, challenges with travel, challenges with childcare, just needing to engage other people in your life, so your support structure, to help them understand what's going on with your disease and how to help care for you at home. All of these needs are highly addressable, and when addressed, can improve outcomes, particularly in our ethnic and racial minority groups. So, this is a worthy cause for all of us to understand and improve, because one of the lowest hanging fruits for improving outcomes in rheumatology care is to help get rid of these disparities and ensure that all of our patients are able to do just as well with the advances that we're making in rheumatology.